and welcome to Public Health Musings. I'm your host, Dr. Caroline Kingori. I'm a public health faculty at Ohio University, and today I'm joined by two special guests. And these are my mentees, and they recently defended their dissertations, and so I just nabbed them immediately while they still have their research fresh in their minds. So that we can talk about the work that they've been researching on and how they got to this point today. So I'm very glad to have two amazing scholars here. We have Dr. Mary Chumbow and Dr. Nancin Dadem. And so I'll introduce them to you. Dr. Nancin Dadem completed her PhD in health communication at Ohio University. And she worked as a research specialist for 12 years, exploring critical issues that influence the uptake of adherence and retention of antiretroviral therapy in Nigeria. Her current research centers on the promotion and prevention of and preventive health behaviors. She explores individual, relational, and contextual influences on women's health behavior, especially where disease prevention is possible and available. She investigates social and behavioral dimensions of health and seeks culturally centered strategies for intervention. Her awards and recognitions include Outstanding Performance, University-wide Research Awards, and honorable mentions for excellence in teaching. She received her BA from the University of Jos and an MA degree from Bayero University, Kano, Nigeria, and she enjoys family time and traveling. My other guest is Dr. Mary Magdalene Chumbow, okay? And she's well known as MM, so I'm going to call her Dr. MM, is a media arts and studies research scholar from Cameroon, and her interests lie in women's studies. Her work mainly focuses on sexual, gender-based violent practices among African communities, as well as the role of feminism in media and communication. She's interested in the representation of women and women's agency as enabled or suppressed by the media, the work of women self-help groups, and as well as using feminist and African womenist research tools and methods to learn about the lived experiences of these African women. In her free time, Dr. MM, together with her son, create digital content for their family. They have a TikTok page, and they co-host and produce a family YouTube channel known as Being Chumbow, the Ultimate Family Show. So it's really exciting to see how they have all these other things that they are engaged in outside of just being scholars and being just fantastic scholars in the work that they're doing. So everyone join me in welcoming Dr. MM and Dr. Dadem to the show. Yay! Fantastic.
Yay.
I'm so excited to have you guys on the show and to just see these amazing mentees. Just letting the viewers and the listeners know that both of you are my mentees, and I've really had a fantastic time. You made it so easy. I've learned so much from you guys, learned so much from your research. And, today we are going to focus on women's health in Africa. Based on your research work and what you recently defended in your dissertation. So that we were able to know more about you, can you both share a bit about your background and how you became involved in researching women's health issues related to Dr. MM, female genital cutting, and Dr. Dadem, cervical cancer? So tell us your story. How did you get here? And you're going to start with you, Dr. MM.
Oh, okay. I just want to say thank you for having me here, Dr. Kingori, or Dr. K, as I keep calling you. And yes, you have also been an amazing mentor. Well, so my background actually starts with me being raised up in a pastor's house, in a preacher's home, and seeing a lot of people running to our home growing up for help, for shelter, for support from my parents. And at first I used to be very offended having these people like, why are these women entering my bedroom and staying here for months with their children crying in the middle of the night for me? But then I started eavesdropping. You know how kids would be sent away in African homes when adults are having conversation, kids are sent away to go and be in their bedrooms. But then I would sit at the top of the stairs and try to listen in on the conversation going on downstairs. And so slowly by slowly, I started listening and really hearing like They're running away from very abusive relationships. They're running away from very unfair conditions or mistreatments that they were facing in the hands of spouses, in the hands of their parents. Maybe they got pregnant before marriage and they were chased away from their homes. And so then I started having empathy. Like I started understanding what they were going through and started just appreciating the fact that they found somewhere to go to. And when I also eventually did get pregnant at 17 and gave birth at 18, I was like, okay, now it makes sense. At least I have parents who welcomed me and accepted me, even though they were angry. But now I see that could have been me if I had been in the hands of other parents or other people. And so that is where my empathy started, from growing up and seeing other people coming into our house. I can tell you for sure that there was not 1 month that passed without other people occupying my bed or my sister's bed, and then me and my sister having to share a bed. Our room was always like a refugee camp. I like to say that, in terms of like, it was always clothes all over. We would arrange it, but there were bags, those big African bags of clothes for people, different people. My study table became everybody's study table because all the kids would all sit at that table to study. So I have a lot of people I call cousins. I have a lot of people I call aunties who are not like my blood relatives, but they're people who I grew up with and they lived in my house. So I grew up with them and I call them my cousins. That's where it started. And then, being a Cameroonian who grew up in Kenya, we always heard about anti-FGM, anti-female genital mutilation. This is like a very horrible practice. I went to school with Maasai girls. I went to school with people from Kajiado. I went to school with people from Turkana, but they never talked about it. But then one day, a friend of mine told me about how it almost happened to her, how she almost went through female circumcision. And I didn't know what to say to her. I didn't know how to respond. I didn't know whether to be angry about what happened or hug her, or like, it was just so confusing. And so that is one of the reasons why when I joined my PhD program, in my master's program, I had done a study on breast ironing in Cameroon, which is my home country. So when I joined my master's program, I was like, I want to make a bigger project of the same thing, but now focus on female circumcision in Kenya, because that's where I grew up. That's where most of my friends are from. And that's where many of the women I interact with come from. And I knew that I could go back and be in the field and participate and be with these people and kind of be like part of them and not like a complete outsider. So that's why I got into female circumcision.
Wow, that's such a compelling story. How about you, Dr. Dadem?
Yes, thank you, Dr. K, for having me also. I enjoyed you thoroughly on my committee. I was just saying so before the show began. Yeah, so for me, how I came into researching about cervical cancer. So in part, it was part of my lived experience, in the sense of the fact that I was working, like I had said, exploring social and behavioral dimensions of HIV and AIDS in Nigeria. And so in that urban clinic, I felt that was the first time I heard about cervical cancer, right? So there was a project that was going on, and both staff and those who come to the facilities as clients were being asked, right, to go for cervical cancer screening. And I thought, I had never heard about that before. And how come I'm just hearing about it? And at the same time, they were talking about, the rates were escalating and all of that. And I'm like, so how come I do not know about cervical cancer? All I know is breast cancer and the other forms of cancer. And so I had the screening done in the same facility, turned out good. And then I can't remember how many years after then, I had to go to now the very big facility in the town. And I went in there and there was a teaching situation going on. And that meant that a male, healthcare provider was going to come in and also take the screening. And I didn't want that. And so I just turned around to the women around and I asked, does this person also go to take the pap screening? And they were like, yeah, you're in a teaching hospital. And I said I did not want that. But because I wanted to hear from the healthcare providers themselves, I waited when it was my turn. I now asked her, is this guy also going to go in? And she said yes. And I'm like, no, I don't want. And then I left. Now, the next time I heard cervical cancer screening was here in Athens, Ohio. And so for me, when I began contemplating what topic was worthy to be problematized in my doctoral agenda. Then I thought about my lived experience, and I'm like, okay, so if I was working in a healthcare facility and I was just knowing about cervical cancer when I did, maybe about 2014, I think. Yes, and I did. How about those in the regular communities? What information do they have? Because I also lived on ground there. So I knew that I only heard about it within the facility. And I said to myself, this is an issue. And for me, if I could not have a healthcare provider respect my own preferences, and then I felt it was going to also become a barrier for other women, because I walked out and I said to myself, I wasn't going to do it. And so that became, a topic that was worthy for me, to investigate. And then from then on, I knew I had to do that, for women who are minoritized and actually underserved in our environments. And so that began my journey into researching into cervical cancer, or into women in general. Yes. Thank you.
Yes, great. Thank you for both sharing your stories and how you came to be interested in those research topics. And there looks, again, like there's a lot of lived experiences and personal testimonies, if you will, that got you to where you are today. And so for the people who don't know what cervical cancer is, or what female genital mutilation is, or now what we call female genital cutting, I think this is a great time to give a small intro of what those two health issues entail. And so we'll start with you, Dr. MM. What is female genital cutting?
Well, the general description given by the World Health Organization about what female genital mutilation or female circumcision is basically the traditional rite of passage that involves the pricking or cutting of girls' genitalia. And it is usually done on girls below the age of 15. So in my research, I use the term female genital cutting, and that is just basically separating that term of mutilation from the practice, because most of these women do not consider themselves mutilated. And that is something we can talk about later on. I'm sure we're talking about it today later on in the podcast, where the term mutilation is more like retrogressive, and it's more like trying to say that this is the only way a woman should look and any other way is horrible, and it's defying everything else. And so female genital cutting is basically my way of respecting these women's choices. And so I call it, or I refer to it as female circumcision or female genital cutting, because that's how they call it circumcision basically in their languages, in their different dialects.
How about you, Dr. Dadem? What do we need to know about cervical cancer?
Yes. So cervical cancer is the cancer that occurs in the cells of the cervix. And the cervix is in the lower part of the uterus, which connects with the vagina. And cervical cancer, the causative agent is the human papilloma virus, which is largely transmitted sexually. And the risk factors of having that infection includes early sexual debut, like below 20 years, and having multiple sexual partners. Yeah, so that is that. And then what increases the risk of HPV developing into cervical cancer, you have issues of age, the disease occurring after 40 years, you have family history, you have tobacco smoking, and then something that is particular to Africa south of the Sahara, where Nigeria belongs, is the presence of HIV and prolonged HPV infections. So you have those other general, risk factors. And then when you come to the population or to the area where I situate my research, you find, newer additions of the risks to the development of cervical cancer. And importantly, HPV, prolonged HPV infections, and then the presence of HIV AIDS. Yeah, so that is that about cervical cancer and the route for infection.
I appreciate that introduction there, and it really helps set the stage for the robust discussion we're going to have, considering that this is a health issue that is occurring in a heavily cultural and religious communities in different parts of Africa. And so it's important to situate that in our understanding of how to address these health issues. So for you, Dr. MM, Describe those cultural and societal factors that contribute to the practice of female genital cutting in Africa.
I would say, as you just mentioned, the first thing that we have to acknowledge is that most African countries are highly religious, especially in the sub-Saharan part of Africa, highly religious, even in the northern part, which is not sub-Saharan. They are very religious. They're either mostly Muslims or mostly Christians. And so many of these women who live in these communities where female genital cutting is practiced are also highly religious women. And at the same time, they're highly religious with Abrahamic religion like Christianity or Islam, but they are also very religious in terms of African traditional religion or practicing African traditions. And so they will, at most times, in most cases, they will overlook their Christianity or their Islam to practice whatever their culture says. So you'll hear a lot of people talk about, oh, that is not how we do it in our culture. This is not how we do it where I come from. This is not how we do it. This is not the way a woman behaves. When you give birth, this is what you're supposed to do according to culture, not according to the Bible or the Quran. So the first thing that affects any practice in those communities will be their religion or their belief systems. And then the second thing will be the structure that in which the way the community is structured. And so in most of these communities, it's very patriarchal. It's very like the man is the head of the family. Everything is being done in such a way that we're doing everything to appease the man first. And so the reason that some would give even for practicing things like female circumcision is just that we're doing it so that this woman, if she ends up getting married to a polygamous man, for example, will stay at home and not go looking for other men to be with while the man is with the other woman. So that's one of the examples for the reasons that is given, for example. The other thing that you could say that affects it is also the lack of resources or the lack of accessibility to resources for many women compared to men. So men have higher rates of literacy. They have high access to medication and jobs and all those things. Women are more unemployed than men. Women have lower rates of literacy. Women do not have as many opportunities as men in terms of finding jobs. They also are not able to in some communities, what the man says goes. So they're at the bottom of the structure, of the hierarchical structure in terms of how the society is structured, and that also affects what they practice and how they practice it.
Yeah, I appreciate that feedback there. So what you're telling us is that outside of just the culture and religion, we have these socioeconomic factors that intertwine with why we have this practice. So outside of the patriarchy and the settings that we have for each of these communities and the social norms, the socioeconomic factors play a big role too, right?
A very big one, yes.
Okay. How about you, Dr. Dadem? In the context of Nigeria, and we know it's not just a homogeneous country, we're thinking about heterogeneous groups there. And you think about cervical cancer, what are those cultural and religious factors that we need to consider, as well as how can providers be better equipped to provide culturally sensitive care to these women who are at risk or have been diagnosed with cervical cancer?
Yes. Okay. So again, tying back to culture, because that influences, for example, risk perceptions. And so when you operate in a culture like the Nigerian one, where religion plays a very big role in people's lives, you hear women talk about, oh, it is not my portion, right? When you talk about their risk perceptions and they do not think that they're susceptible, to cervical cancer. So it is not my portion. What have I done to God for him to allow the sickness get to me? I reject it in Jesus's name, and all of those, religious values and things, that they hold dearly to themselves. And so that affects risk perceptions where women do not think that, they are at risk. And then you also have the expectations of chastity. Now, HPV is largely sexually transmitted. And so if that is the cultural expectation and the values that are attached to that, why would a single lady, for example, want to go test herself for cervical cancer? Because there's an expectation that she's not engaging in sexual practices. So that becomes an access barrier for her from the get-go, because she knows that the expectation culturally is that she should abstain, right? There's that expectation of chastity. And so because of that cultural expectation, it becomes an access barrier for the single lady to go test herself, even when she is engaging in sexual activities. And then again, the same issue of patriarchy. So you have women who are not financially empowered, because again, it is the man's call. He's the breadwinner. And so for everything that a woman has to access, even medically, it goes or passes through the man who is more financially empowered to do so. And so he has to give her a clearance to be able to have the screening done. And then you also have the procedure itself, where you have to open up. And now in communities that are more close and are more, I would use the example in the far north, where ladies, cover, and then the hijabi and all of that kind of thing. So it becomes a problem. Now and again, linking back to my lived experience, where a woman has to open up herself. She has to open her vagina for somebody to take it. And that is not a cultural thing to do. So again, going back to what you said about the healthcare providers need to embrace patient-centered care, where they prioritize the needs and the goals of the patients, where they offer empowering informational and emotional resources, where they understand the cultures and the values and the practices of the people. And so if you respect that patient to that extent, then you will take into consideration their preferences, who takes their pap smear, right? And things like that. So the healthcare providers should know that the patient has an agency, and respect that, because now it is about the care of the patient. So if a female chooses to walk away because they're not respecting her own culture that she brings into that experience, then you have not delivered patient-centered care. So that is something that healthcare providers need to understand. And they also need to understand the culture. So that again informs how we do health communication campaigns, right? So are you campaigning over public mass media? While we understand that for communal settings, that interpersonal communication and group communication works. So how are you deploying education and awareness and information into a culture where people prefer to hear from family decision makers and to hear interpersonally? So this again is a cultural aspect. So how are we educating women, and how are we ensuring? So it is not just about providing information. How are you ensuring that they actually go to access pap smear screening? So that is the question. There's an issue of awareness, which is done using mass media, but who is going to assuage the fears of the woman? So we're going to talk about, the barriers and the challenges in accessing pap screening services. So one of it, for example, is the fear of a positive result. Who is going to assuage the woman's feelings when she's afraid? What does it mean for me to have cancer in Nigeria, where the healthcare systems, are not up to standard, or where they should be at the moment? So yes, this is what healthcare providers can actually do culturally.
That's so interesting and loaded. And I can see similarities also for what you're doing, Dr. When these women who have undergone FGC or female genital cutting, and they have to go to the hospital, and they also have to undergo these screenings. How does that look like,
Yeah, I was actually, when I was preparing for my dissertation defense, I was reading a book written by one of the women who has gone through female circumcision, who is now in the United Kingdom. And she was giving her experience the first time that she went into a clinic, and and she was pregnant, and they were doing the prenatal checkup, and she was very uncomfortable. In her head, she wrote about the kind of questions that were running through her head as all these white doctors whom we can still say is just a different type of person from who she is, because if we're in Nigeria and I've gone through that, and it's a man looking at me, it's the same thing as if I'm an African woman who who has gone through it, and I come here in the West and I'm being attended to by white doctors. So she was like, what are they thinking? And as soon as they left the room, she just thought they were going to call the police to arrest her. And so it was like, she's afraid. First, she's afraid that she could get arrested. Secondly, she's scared. She's wondering, are they thinking I'm a freak? What are they thinking when they look at me down there? And thirdly, are they actually going to do what they're supposed to do, or are they just going to be concerned about the situation? And so when you think about the emotional turmoil that she was going through, just be lying down there with her legs up and them checking, you can imagine how many women go through that. And if they have to go into a room where it's a male doctor checking them for another thing that could add more turmoil to their lives, that is like very scary. And I can imagine many of them would not want to go into that room. Or in some cases, also in Africa, most gynecologists are elderly women younger women will not feel comfortable showing that they are sexually active, like Nancin said, or in any way try to talk about their sexual lives with those people. So yeah, it can be very scary.
Thank you so much for that perspective. And this really segues greatly to the discussion on the challenges, especially like what Dr. Nancin had started talking about. So from you, Dr. Dadem, what are some of the challenges in accessing quality healthcare and cervical cancer screenings for women, especially those in low resource areas like the rural places in Nigeria?
Yes. Okay. So the challenges for pap screening in Nigeria are quite many. Literature reports a lot of lack of information, right? So from my own research, there was high awareness. And I believe it was because these were women who felt comfortable. They had done the screening. And so they felt comfortable, for example, to want to share it in an interview situation. So a majority who had not done that, I would assume, just turned it down. But there's a lack of information on the disease itself and the pap screening procedure, lack of information on, screening locations, low risk perceptions, locations in general, right? Because you're having urban centers where people are second guessing themselves, where can I access this treatment? And then you think about the rural folks and their own situation is more serious than that. And we also have the high cost of screening. So while some particular locations, for example, I had 2 different locations, for example, in my research. And one was, I could say, affordable. But then as soon as you begin to move from the government hospitals and go into the private hospitals, and then in a particular location like Abuja, which is the Federal Capital Territory, and cost of living is very high, then the prices are very high, so it also constitutes a barrier to access for women. So these are some of the factors that, or the challenges of pap screening. And then, of course, you have issues of shyness because you have to open up in the procedure, just that general lack of information, the fear of pain because they have not gone through the procedure already. And then I've heard women say, even just going through, into the rooms, into the screening rooms, and they see the tools coming out and they become very scared until the nurses say, calm down, it's not going to be painful. Until they're able to experience it themselves, they keep sustaining those fears, right? Yeah. So these are some of the challenges of accessing pap screening in Nigeria.
Fantastic. And to add on to what you had already started discussing, Dr. What are some of those challenges in working towards ending female genital cutting, and how can these challenges be addressed in places like Kenya, where you conducted your research?
I think the first challenge would be that this practice is very traditional. It speaks to who they are as African women, as Kenyan women, as a Maasai woman, as a Kisii woman. This is the practice that determines that I am a woman in this community. I am a woman in this society. And taking it away from me without giving me an alternative, without telling me this is another way which we could work together to come up with a solution that all the girls in this community can feel as women, then you're not telling me anything. I am still going to try and find a way to become that woman. If my community keeps telling me that this is what I have to do to become a woman, and if I have to go through this for me, even in myself, to feel as a woman. And if I am not to be ostracized by my community or other women in my community, then I will want to keep practicing it. And that is the first thing, the fact that it is a part of who they are and it informs who they are as women, especially in those communities. That's the first challenge that I think that is why, even though like in Kenya, the ban was placed in 2011, but up to now it's still being practiced. It's not as prevalent as before, but it's still prevalent in many communities and they're still practicing it. And it is because of how traditional it is and how much of a part of who they are and their existence it is. Secondly, it's just not involving them in a process of trying to like end it. If you are coming into a community and you want a practice that you have proven on your own that it is detrimental to the growth or the development of the people of this community, but you have not come to them to speak with them, to find out what other alternatives can we come up with, how can we talk together to reach an agreement, and you're just coming here and saying this is the solution from now on, and if you don't follow this solution and if you don't follow this law, we're going to arrest you, we're going to fine you, then guess what? People will be scared, yes, but they will still find ways. I mean, people commit crimes every day, and this to them is not a crime. Okay, you're the one who has told them it's a crime, but to them it's not. Being a thief is a crime. That's a general one we know. Being a rapist, being this and that, but to them this is not a crime. So they're going to find a way to keep doing it. If thieves have been able to steal and keep stealing, and they're not being caught, and they are doing something that they believe in and they truly believe is right, they're going to find ways. And that is why we have found, like in my study, I found out that people are now medicalizing female genital cutting. They're taking their children and their daughters to doctors or health practitioners, local ones, or in a place far away from where they live to actually carry it out. Or in some cases, it's also done, but in secret. It's no longer a celebration as it used to be before. Before, it was part of like a whole celebration. You come with your peers, you guys go through it together, you stay in healing together, you sit and heal together. And as you're healing, they're educating you about the ways of the culture. But now it's being done in secret. And this being done in secret actually makes it even riskier because you don't know who's handling it, who's doing it. Before, it was one woman, one assigned person, and then they had apprentices. But now we don't even know. Like you can't really know. And it's only until when you're ready to circumcise your daughter that you start asking around, and someone will tell you about someone in another village, and you're just going to go there and do it. And if anything happens, you can't even go and report it. You can't take your daughter to the hospital if they're feeling unwell or if they're going through something, because you're afraid that if you take them to the hospital, you're going to be arrested. Your daughter is going to be taken away from you. And so that is a challenge again, because people are going to keep practicing it because they want to keep they want to be women in their community. And also because they're defying you. You've come here without telling me, without involving me in deciding in this decision, and you're telling me what to do. I'm a grown-up. Someone actually asked me, you tell us why they're telling us not to do it. Like in the field, they asked me. And another one was like, these are our bodies. And I agree with them. It's their bodies. We are all here about, if we're feminists and we're all about human rights, we all keep saying it's my body, my choice. So they're also right to say it's their body, their choice. I mean, at the end of the day, it is their body. So how do we involve them in the conversations that will reduce the practice if that is what we all agree with them as well on the table, that this is wrong for them? I think those are the two main things.
Okay. Wow, that's really good to know, Dr. MM. Sometimes we don't realize that even the folks who we think are disenfranchised, they don't think that they are. And there's some sense of ownership and identity in some of these practices, even though they are harmful. And I like the idea of what other alternative for initiation can we offer them. And so getting into those alternatives or solutions, Dr. Dadem, I would like to know, are there any successful or promising interventions that have been developed in Nigeria to prevent and or treat cervical cancer?
Yeah, so some of the strategies that have been put out there in literature and other researches is for the fact that healthcare providers need to educate women when they come to the clinics. So women come for antenatal when they're pregnant, they come for family planning when they're done, having given birth, and then they also come for pediatric care for their little babies. And so healthcare providers have been urged and encouraged, right? And even through the interviews and on the field work, I realized that most of the women who had done Pap screening was at the instance of their healthcare provider's recommendation, right? So it was either through one of those clinics, or they came presenting with other, illnesses that led the medical personnel to ask or to demand or to require of them to have Pap smear screening. And so this is a strategy that has been largely pushed out there in the Nigerian space. And then, of course, some others also mentioned the fact that they had heard about Pap smear screening from the public media, either social media or through radio or through television. But when you ask them, right, so what motivated you? What influenced you to screen? Then they push out those other information about getting it from a family member, from a friend, from a doctor, now linking it back to those interpersonal communication, right? Where they were able to have a one-on-one and to ask questions and to be given information that sounded critical to them, or even through groups. So you hear things like, okay, we had a support group now for those who also have comorbidities, with something else. And so they were informed about the need to screen. And so again, tying it back to the interpersonal. So that is that. But then something that I did in my own research was to ask, so what would facilitate, what are the conversational attributes that can facilitate and, ensure that women screen? And then you have issues of polite communication, where healthcare providers just need to communicate with them in the languages they understand, to communicate in a way that is friendly, because already we're talking about the disease that has an implication in death, right? So yes, but something again that kept on coming on was that women were just informed to go have Pap screening without having the information. What causes cervical cancer? How can I prevent myself? And so this kind of information they do not have. While they're aware of Pap screening, they are not sure of what it means, to prevent yourself and what causes it. And something that is very critical is that I kept hearing women talking about the responsibilities to share this information themselves. But if they're not equipped, if they do not have this empowering information, then how are they going to be able to share with other women? So even women who had tried, you hear somebody saying, I took 7 women with me, only 2 decided to do that because she did not tell them that it was going to be through the vagina. They thought it would be something taken through their blood. And so they left. So something that is important to note is that interpersonal communication is going to be very strategic in ensuring that women screen for Pap smear, because it is the women who can use themselves as example. I screened. It all went well. It is not painful. Prevention is better than cure. So they're able to assuage those fears that come up rather than just hearing it over public media and saying and expecting women to go for screening. So these are the strategies that I'm canvassing for. And of course, perceived stigma came out. Again, there was no real stigma because they're not aware of the route of HPV. So they just perceive, for example, for those who knew that it had to do with, sex or something like that, they perceived that there will be stigma involved. And of course, from researches done on HPV vaccination, which again, I would say the vaccination was approved in Nigeria in 2009. I think I don't want to mix up the figures, but sometime down the line, but it has not been incorporated into the national program for immunization. So you only have people accessing that vaccination on their own, personally, through maybe private health institutions and that kind of thing. And then researches that were done on HPV vaccination also linked that to stigma. That means you're giving license to adolescent girls and adolescent boys to go engage in sex. So again, there comes in the issues of stigma and the issues of, culture, tying all together. But what would work, again, interpersonal communication, one-on-one, group communication, for example, in women's fellowship, where you bring someone who is knowledgeable about cervical cancer and can share with women. And so that questioning and receiving feedback, is what they prefer. tell me about this problem and let me have an opportunity to ask questions. And then they kept talking about the fact that we need to be empowered with information and prevention. So again, that challenges the use of fair appeals in, public health communication campaigns. So these are the strategies that are promising for educating women and ensuring that they uptake of screening services.
Wow, that's really great feedback. And often we assume we know better as whether it's researchers or it's healthcare providers. So same question to you, Dr. MM. Are there any successful or promising interventions for female genital cutting? What do they look like?
Yeah, so as I mentioned earlier, the government has banned the practice of female genital cutting. And so many communities now, the way they have heard about it, as Dr. Nancin has also said, it's very similar. They've heard about it from the media. They've heard about it when a chief comes in from nowhere or an official and says that's their role. And it's an office that's opened up in the local community office where they're in charge of FGM, anti-FGM board. And then, so the first thing that is happening is that institutions like churches and mosques are being involved in talking to the local communities. Pastors, imams, they're very involved right now in talking to these women about, or in like organizing programs, like intervention programs that can just help in like educating them, informing them about the things that have been found. And now in some areas where the women are being involved in organizing these intervention programs, in some areas where the women are part of like panels where we're all sitting together to talk about it. And it's not an outsider coming to just give me information and show me a scary video of a woman who has gone through female circumcision who's suffering. When they're involved in it, it has had more effect because like I know one of my participants is actually a social worker now who goes around talking with other people about her experiences and talking to them. And she was one of the most vocal ones against the practice among my participants. And so I can see, and even in the Maasai community in Kajiado, where I spoke to some women, they were actually very happy now with where things are with them and the church. When it first started, they did not welcome these people who came in. Then the church took it over. The church now organizes like during circumcision period because they know these periods. The church is the one is by someone who's a local member. So they know these periods, they're trusted in the community. So if I come to you as the pastor and you trust me and I say, I'm taking your daughter for 2 weeks during the circumcision period, we know what you're trying to do, but we trust you more than we will trust a government official whom we don't know. And so the church is also doing that. The church is now taking girls away for like a 2-week camp during the holidays, where they learn other things, other skills, doing dishes, washing, going out into the fields to play, just being girls. And then the boys are assigned, like families identify a sort of godfather who goes with them during the circumcision period, takes them for the circumcision, and then they go into camp as well. So it's the same experience. The only difference is that the boys are now taken to actually get the cut, but they have a mentor assigned from the church who goes with them, and that's in some communities. And then in other communities, like I mentioned earlier, especially like the Kisi community, it's now very medicalized. They do it in a medical setting where it's supposedly more clean, more pristine, more sanctified or clean, like just very, very white and clean and pristine. So it's like a medical procedure where they go in there, a medical official does it, and it's still illegal, but they prefer that. Like it's working for them in that way. And from research, it has shown that there are less cases of complications, post-FGC complications, just because these are individuals who are not medical quacks, but actual medical officials who are doing it. And if anything happens, they also treat them in private, in secret, but they're doing it and it's helping these girls to become women in their communities, but also keeping them from getting into any issues. Finally, I just think the other one which has worked is alternative rites of passage among the Meru people of Kenya, is basically where the women we do other forms of initiation. We take out just the cuts or the pricking, and we do everything else that was entailed. So if we were coming in as a peer group, we come in with our peers, we do the dancing, we do the ceremony, we even throw ash on our body, we dance, we have fun, we eat, we drink, we have a good time. Then we stay together for the rest of the week with our mentor. It's always one female elderly woman who will stay with us and educate us. And that's still initiation. So it's just getting to a point where we can get other communities to see which one works for them. In the Kisi community, it's medicalizing it. That has worked. In the Mero community, this type of initiation where we just go dance together and live together for a week and learn the ways of the community as women of the community, it's working. In other places, the church is finding other ways. So if we can, I think it's not a one size fits all for everybody. And so the challenge comes in finding the right size for one community, then going to the next community and finding the right size and keep going and going. I think that is what should be done. That's my suggestion, basically.
Yeah, I like that perspective and sort of a fresh way of looking at initiation. And like you said, these communities are looking for an alternative of, moving these young people from one stage to another of the lifespan. So for both of you, what are your thoughts about how what role men and boys can play in ending female genital cutting or increasing awareness for cervical cancer? So we'll start with you, Dr. Dadem. How can we involve men?
Yes, I remember one of my participants or two who, clearly spelled out how we can do that, right? Especially for communities that are farther up north and are farther in those areas. And she mentioned the fact that men had to be involved because, again, it has to do with their wives, thinking about, the population that would access Pap screening for ages 25 and above, as WHO would say. And so using men or involving men in the education and in stigma reduction strategies is very important. So what she said, let me speak again through the voice of my participants. What they said was inform and educate the men to be able to understand that this is key, this is preventive. We're not saying that they already have cervical cancer. They're not going to die outrightly because, again, you remember that there's a fear of death, what it means for, to have cancer, especially in a healthcare situation where, quality is not as optimal as it would. So you have to inform the men and, educate them in such a way that they're comfortable and in such a way that they're the ones who would also, urge their family members, their wives, their daughters, their sisters, and all of that to be able to do so. And then even in terms of providing the finance for them, the resources for them to go to the hospitals, so that they can have Pap smear screening. That is something that is very important. Also for community gatekeepers, again, going back to the role of the church and just community-based organizing, right? Where you have partnerships across with the healthcare facilities in such a way that they're able to empower community members to be able to share this information, because we're now thinking interpersonal and group strategies, even though the government also has its own responsibility in mass mobilization and mass sensitization on Pap smear screening. They have that role to play. And of course, when we think about the rural communities also, where locations become automatically a barrier to, access just because of where they live geographically. They do not just even have this information, right? So government has to think about that. But we are canvassing more for those community-based strategies where we see partnerships and ways of just integrating women, groups, whether they're social or religious, and community leaders themselves to be able to ensure that there's a flow of that information. And I want to highlight the critical role of women, because again, I would say they kept on sharing their experiences from a point of responsibility for other women. And it was not just to inform other women, it was to convince women. So they kept using that word to convince them, not just to inform them, right? So they have a very critical role to play. Lay women have very critical roles to play. And that is something that community-based organizing can do. So finding, that linkage. And again, they, apart from convincing women, they outrightly became a linkage to care because they were now informing them on where to go. So yes, so these are strategies that will work, including male involvement for stigma reduction and for education.
I like the comprehensive perspective you've provided. We started at this individual level, interpersonal, but now you're saying there's a responsibility for the politicians, there's a responsibility for healthcare providers. And this speaks volumes to the fact that women's health is everybody's health. And often we don't communicate that effectively. If you're thinking about family planning, it's often associated with women. But these issues do play a huge role in the society in general. It's affecting the children. It's affecting, safe birth. It's affecting, preventing the sexually transmitted infections and other co-occurring issues. So for you also, Dr. M, what role do you think boys and men play, but also look at the larger society in trying to create awareness and prevent or find other initiation rights and things of that nature?
Well, as a practice that is carried out by women, for women, against women, but it's mainly because they are doing something to please the man, or because they're trying to make girls not to be promiscuous so that they don't end up getting pregnant so that they can stay in school. I do believe that men and boys must be involved in finding the alternatives, in addressing this situation. And the first thing is, first, let's stop expecting women to be the faithful ones if you don't want to be faithful also. Let's think about, okay, what is leading women to do this? Is it a polygamous situation? Then why get involved with a woman if you're expecting that they will be faithful and you will not be faithful? Let's think about educating men about the benefits of being non-polygamous, or if you're going to go into a polygamous relationship with women who are okay with that polygamy, then be okay with having a woman who's not circumcised. So let's not make it be that the woman is the one who has to go through something to keep herself faithful for a man who's choosing not to be faithful to the woman. The other thing is basically also about promiscuity. These are communities where the girl is being punished, you could say, for something that she's going to do with a man or with a boy. So the boy does not have to go through anything that they don't want to. Girls go through this, some of them not wanting it, some of them not even knowing why they're doing it, basically because it's either to keep them faithful for their husbands, or the other one is to keep them from being promiscuous. But boys can also be promiscuous. So how about changing the narrative and not making it about this is why we're doing it, is to keep you from being promiscuous, but also just if it's for just rites of passage, that makes sense. But if it's just to keep you in school, and let's find other ways that boys can be involved in being talked to, because the problem that I find in these communities, and I grew up in the same community, is that if something happens, the girl always suffers the consequences, the boy does not. And yet it involved both of them. When I was in my undergraduate program, the school that I attended was a Christian program in Kenya, a Christian college in Kenya. And when a girl got pregnant, they would expel the girl, or they would suspend them for 1 year or something like that. So if you got pregnant before marriage. And the boys rarely ever, I know a lot of girls who went home, but the boys never, they just kept on with their program, graduated on time, left. So let's stop punishing girls for things that both boys and girls are doing. And let's find a solution where boys are also educated and they can talk to other people. I know a friend of mine and a colleague who they call themselves the Maasai cricket warriors. They play cricket and they're very popular among the Maasai people. And so they are respected and highly respected. So they use this opportunity to go, when they go into those communities to play cricket, or they go to the UK or wherever, and they go within their communities, they spend time talking to fellow men, they spend time talking to boys. And one thing is because men would listen to their fellow men, right? If I am highly respected in this community and I'm a man and I'm wearing trousers and I come before you to talk, you are more likely to listen to me than if a woman comes to talk to me, because they have already assumed that women talk with emotions, women are too loud, women are too aggressive, women just their places in the kitchen and they should keep quiet. But men involving themselves, being that it's a very patriarchal community, it might not be the right thing, but it is very necessary for them to be allies and to be involved in this conversation. So these cricket warriors, Maasai cricket warriors, are very involved in the fight to reduce the practice of FGC in the Maasai community. I know another one of my friends who also started an NGO where he also does the same thing. So, and those are two cases within the Maasai community. I do not know about others, but these are personal people whom I know, individual people. And it's working because they are respected and they are heard. And when men are involved in this, it's just like allyship in any other societal issue. If the person who looks like me comes to talk to me about the situation, I am more likely to listen to them than the person that I've always disrespected or always looked down on, or society has told me does not matter. And so that's the importance of involving men. Men can be involved in talking to younger men, younger boys, educating them, like the church is doing. Bring a mentor who can mentor this young boy and talk to them about other things that are causing this. So if we are having sex before marriage and it's wrong, or it's causing girls to be punished for what we are doing, then how do we address it? If it's anything else, if we have agreed that we are going to go the alternative way of female initiation, then involving men to also support that. Because in some communities, it's the man who's like, I will not marry a woman who's not circumcised. It's the man who's saying, my daughter will not be uncircumcised. So educating them so that they can start understanding that circumcision does not necessarily mean having to be cut, but I can be initiated into womanhood without having to be cut, is also very important. Because when the man speaks in that house, then the wife will be like, okay, now we have to do it. Or if a man says, I will not be with a woman who's not circumcised, now the girls in the community need to be circumcised because men are saying they will not marry us without being circumcised. So having men involved in talking to each other and talking to the boys as they grow up and mentoring them in the right ways, that is very important. Another way is also, men are, being a very patriarchal structure, men are the most in positions of power. So in the government. So if they're drafting bills to be against female circumcision, within those bills, let there be provision for men to also be involved and speak to the things that are actually causing this to happen, because you cannot have a ban on something when you're not addressing it. And men should also take charge in like the intervention programs. If I know that this intervention program is happening, I'm not just sending my wife to go. I'm going with you. I'm walking with you. I'm holding your hand. I'm standing with you. If this is the stand you're taking, that you are no longer going to be circumcised, I'm walking that journey with you. And I am not being an obstruction, or I'm not beating you up for sending our daughter to the camp for 2 weeks. So those kind of things are very important in how we bring together the men, and them also recognizing. But I think it will start when they hear from others first.
Wow.
Other men like them. Yeah.
I really appreciate what you've both shared on matters that are really important in women's health, but also in the society, right? And as we wind down, I just want to know, what has been your most memorable moment in your life or your work to date? Dr. Nancin?
Yes. Okay. Let me say this quickly. When was talking earlier, and she talked about the fact that, women would go access care from women who were younger than them. And that was something that was critical. Again, the role of culture when we do what we do in research or in intervention. And I remember that I had to just involve women who were older. Now think about engaging much younger girls, interviewing older women in a culture that talking about sex is even a problem. And then you are having to ask them about their sexual practices, which becomes a problem. So that is the first thing that I always advocate, those culturally centered strategies, in understanding a problem and also finding solutions. So that was something that was key and significant even from the get-go in my research. And something that has been fulfilling for me is the fact that even the research, even the interviewing became an intervention itself. Because why? The women now understood just from that interaction. They began articulating again, I would reiterate, their own responsibilities to other women. And outrightly, they said, I'm also going to tell other women that I was interviewed on this matter. And I would let them know that prevention is key. And even the interviewers themselves took on that responsibility and the role of informing other people. And they said, we did not know that this information was so scarce. But from the exercise and from, our engagement on the field, we were able to understand the reality, So they took on that burden by themselves and said, we're also going to inform other people. And they spoke without me asking them. And so for me, that was quite fulfilling because, there's going to be a ripple effect. I'm here campaigning and canvassing for that interpersonal approach. And here are women saying, I'm going to talk to my family members who are ladies. I'm going to go to church and ensure that in the women fellowships that they put in these programs, they put in, discussions about cervical cancer and pap screening. And so for me, that became quite fulfilling right before even the completion of my study. So for me, that was something that stood out. Thank you.
Wonderful. How about you, Dr. MM? Any last words and what was your most memorable moment?
Yeah, I think for me, before I went into the field, when I was reading, I had the same very globalized mindset on what female circumcision is and why is it still being practiced? I could not understand. But as I kept reading, I first realized one thing very quick, that a lot of data on female circumcision is very westernized as well. There's very little data that is publicized by the governments of these countries where FGC is practiced. And these are the countries which are in the global south. And so when that was the first gap I noticed. And then I realized I read one article by one scholar who took herself to get circumcised as part of her practice. And she was also questioning the use of the term female genital mutilation. Then I read about a court case where a doctor also took it up to the Supreme Court. She did not win, but she was also making the same arguments. And then I go into the field and these women are saying the same things, maybe using different words. They're using their own way of talking, layman's terms, but they're also saying the same thing. Why are we being told this is mutilation? I have never been mutilated. I have never had fistula. I do not know anybody who has ever experienced this. I do not know all these things that you people keep coming to tell us. We've never heard of it in our community. They could be lying, they could be saying the truth, but the one thing that they're proud of is that their girls go to school and finish school because of this. Their girls are not promiscuous. When you look at the girls from all those other tribes, their girls are promiscuous. But Maasai women, but Kissi women, but Meru women, like they were pointing. But the women I have grown up with, the women I know, oh my God, our daughters are now going to school more than they used to do before. So because now they're allowed to go to school to whatever level, not because before they were not going for any other reason, but just because now education is very important to them. And now they're very proud about that. They go to boarding schools, which is very popular in Kenya, and they come back without being pregnant. Their mothers are very happy. So when I realized that, I was like, okay, then that means we need to rethink how we are addressing this practice. Because if the people on the ground are saying that they're not going through what we are saying that they're going through, then that means whatever we come and tell them, that is why it's still going to keep being practiced. So is this really a problem? Are these women really going through this? And I know that it was just 21 participants out of over 2 million women who have gone through it in Kenya alone. But if there are women who are on this side of the aisle with regards to this conversation, even the women who are against it today are saying they have never experienced anything wrong. And it's just because they have been told it's bad that they're against it now. So why are we calling it mutilation? And that is my my concern now. Like, why are we terming them as mutilated women? Why are we saying it's bad to them when they're telling us it's not bad? Who is going to stop and listen to the other at this point? And I was just like, it was like a learning curve for me. And I was like, now it's time for me to sit back and listen, not provide solutions to a problem that they can tell you very well that it's not a problem to them. It's a non-issue. And if it's a non-issue and we're calling it a societal issue, then we should ask ourselves, are we the right ones or are we the wrong ones? Are they the right ones or are we the wrong ones? And then we find a solution, because this kind of situations, this is where the issue is. The issue is actually the fact that one of us sees it as a problem and the other doesn't. And the one who is seeing it as a problem is majorly the one who doesn't have to live with this experience, who doesn't have to live in this community where it's being practiced. And that for me was like the most important part, takeaway from my study.
Yeah, it's interesting when you have to go to these communities and talk to them. And like you indicated, there are 2 million women who've gone through this, and with a very small sample size, you're right, it might present different perspectives. But what I hear you saying is that we need to have a conversation with them. We need to provide alternative ways, rites of passage, right? Alternative ways for initiation. And we know that there's an expert, her name, I'm forgetting, and she's in Somaliland, and she's a nurse. And this is, she really advocates for the ending of female genital cutting because of what she's seen in her own community. And she's also one of those people who have undergone, just like the social worker that you talked about, who advocates for that. So I think it's trying to bring all those voices and seeing what each of this voice is saying. But I think what I heard from you, it's the sense of identity and wanting a different way, an alternative to this initiation, as opposed to saying the way you practice your culture is terrible. It's probably the stigma associated with that practice, even though many of these women have said that the genital cutting has, it has left them with wounds and pain, and they're not able to have children, or, pain with intercourse, pain with delivering children, pain with menstruation. So I think it's the identity that they have with their culture, and someone from the outside saying that practice is wrong, but the actual action and act does have some ramifications, some negative ramifications for these women. But I think it's for them to feel that sense of belonging and respect. And if we provide these alternative ways, but through having a conversation with them, I think is what I hear you saying here, a sense of respect, like you said, Dr. Dadem. These women want to be heard. They want to go to the clinic and not have to find a male provider there. They want to have orientation of the expectations of having to bear yourself naked when you have to go through that painful procedure, when both of them are painful procedures too. So very complicated topics, but the lessons learned here they're really impactful, and it's something that, the next thing for you all post your dissertation and going into your future careers, hopefully you will continue striving to discussing more about this and finding ways to rally and advocate for more discussion and policies to support work that will enhance women's health. So I want to thank you for coming on the show and to wish you all just all the best in what you do as you move forward. You'll be graduating in a couple of weeks, and I just want to say I'm very proud of you all and for representing the continent and doing great work with the research that you're doing. And yeah, for the listeners and the viewers, you can always find us on any audio podcast, and we are also on YouTube, and we look forward to having you all on the next episode. So great having you, Dr. MM and Dr. Dadem, and good luck in everything that you do.
Thank you so much.
Thank you so much.